Good evening, everyone. Thank you for joining us for this webinar. My name is Natasha Monfort. I'm a third-year radiology resident at the University of Oklahoma, and I'm the chair of the Women in IR Committee through the RFS. Dr. Isabel Newton has been super kind in doing this webinar for me tonight, and so I'm going to go ahead and introduce her. I'll do a few quick housekeeping things. This is going to be recorded, and we'll post it to the YouTube channel in the next couple of days. And then after, once we get started, if you have questions, there is a button that says you can raise your hand, and Dr. Newton and myself can see that, and we'll click on it, and then you can ask your questions, because Dr. Newton would like this to be interactive. So without further ado, we will get started. This is Dr. Isabel Newton. She is an MD PhD who did her undergrad at Princeton and received her MD PhD from Wake Forest. She completed her residency and fellowship in IR at UCSD, and she's currently an assistant clinical professor at UCSD. She's also a chairperson on the board and the secretary for the Interventional Initiative. So thank you, Dr. Newton, for being here, and we'll go ahead and get started.
Okay, thank you, Natasha. I appreciate the invitation to come speak tonight. And like she mentioned, this is meant to be interactive. And, you know, you guys are kind of at the beginning of your careers, but this is about the future of interventional radiology. And we're looking at the future by kind of gazing at the past and trying to put it into perspective. And I've had the benefit of being able to talk to a bunch of really great luminaries over the past 2 years as part of a project that I've been doing, or a couple projects that I've been doing. Been flying around and talking to people who have given birth to this field and helped shape it in various important ways. And so this talk kind of represents the amalgamation of their wisdom with my perspective. And so, you know, it's left to our conversation, and we can see where it takes us, okay? So just to go through, you may not know these people because you guys are kind of new on the scene, but I'll just go through a couple of them. John Abley actually was one of the founders of Boston Scientific, which is a company that makes a lot of catheters and things for interventional radiology. Greg Alzate is an IR in San Diego who's actually featured in the documentary Without a Scalpel. His mentor, Hal Koons, is an innovator in a lot of biliary types of procedures and is also featured in the documentary. Frank Fascini is the chief, I think I don't remember his title, it's something like, you know, Emperor on High of BTG. He's got some real title, but it's not that. But he's also the head of a very successful practice, freestanding IR practice in Chicago. Susan Jackson is the executive director of Western Angio and also co-founder of the Interventional Initiative with me, and co-producer of Without a Scalpel with me, which is the documentary. John Kaufman is the head of the Daughter Institute and just a wonderful guy who is a true luminary. Barry Katzen founded Miami Vascular and is also a true luminary. He has understood kind of where IR should be going from a very early phase, even in 1987, and has been kind of pushing the frontiers in that direction. Fred Keller was a disciple of Yosef Resch and daughter, and actually preceded John Kaufman as the head of the Daughter Institute and is a true luminary still working there. Ann Roberts is one of my mentors, has been a big leader in the fields of IR and radiology, and if you've ever done a UAE, you may have used her catheter. It's the Ruck Roberts catheter. And then Yosef Resch was the kind of right-hand guy to Charles Daughter, and everybody kind of knows about Charles Daughter, but Yosef Resch is really as important, or in some ways more important in terms of his contributions to our field. So I have had the pleasure of speaking with all these people, and these are people that that you know, whose opinions I value greatly. So I'll move on. So the objectives of this talk are that, you know, we all of you who are on this call undoubtedly appreciate the value of IR, and that's why you're wasting an hour of your time with me. You know, it has so much to offer patients and so much to offer our healthcare system in general. And so it's astonishing that so few people have even heard of it. And, you know, if you need proof of this, just on your next plane ride, when somebody asks you what you do, just tell them you're an IR, and they will look at you with this kind of blank stare, and then tell them a little bit about what it is, and soon they're going to want to know everything about you. They're going to want to understand what you can do, and if you can help their grandma and their uncle. And what happens is patients don't find out about this, even if they can benefit from it. And oftentimes they're actually referred to IR as an option of last resort, which is sad, because, you know, we are often so good that what if we were the option of first resort? I mean, those would be the chip shots, right? And the reason why we're good is not because we've got these giant egos and we think we're amazing. It's that when people keep sending you the hardest cases with the highest risks, and you keep finding solutions for patients in a safe way and keeping them whole, it makes you very good at doing just that. So in this talk, we're going to examine our past in an attempt to understand why IR is unrecognized, and even some would say marginalized within the healthcare system. And I sort of feel this sometimes. I just came off of call last week, and I'm like, why, you know, are we being regarded as if our opinions are less important or carry less weight than any other member of the team? We're going to assess common fallacies regarding where we went wrong and what we should do to advance our field. And so you may hear people talking about these things, and I want you to understand kind of where from and separate fact from fiction. And then we're going to take some lessons from our history to suggest ways to increase opportunities for IR and improve patient access to our services. So how does that sound? Great. All right, good. Okay, so this is, you know, a quote that you probably have heard in part at some point in your life. It's that, you know, those who can't remember the past are doomed to repeat it, or are condemned to repeat it. And actually, IRs are pretty much a setup for repeating the past, because most of us actually weren't around when the past was forming. IR as a specialty is a very young specialty. The vast majority are younger than the age of 55 and even younger than that. And so many people can't remember, you know, the beginnings. You know, if I ever want like a reality check, I ask Ann Roberts, hey, you know, how did you guys used to do this? And she's like, oh, shoot, you know, we used to put in a 25 French catheter in the neck and yada, yada. And I go, wow, that's a lesson in latitude, because, you know, we think that this holy way that we're taught now is the end all be all, but it turns out that there have been, you know, huge changes and improvements along the way. So recognizing that and learning from that can be invaluable as we move forward. So where did it all begin? And, you know, I mentioned a bunch of names at the beginning, and these are people who you probably heard in passing, or maybe you've never heard of. But these are people who are important because they made possible a field that not only gave, you know, rise to interventional radiology, but I would argue have changed medicine completely and pushed all the frontiers towards a more minimally invasive approach. So back in 1963, one day after my birthday, many years before I was born, at the Czech Radiological Congress, Charles Dotter uttered this statement, which has become incredibly famous. And he said, "The angiographic catheter can be more than a tool for passive means for diagnostic observation. Used with imagination, it can become an important surgical instrument." And he said this before he ever did anything. 6 months later, he was doing this. And this woman here holding this angiogram is Laura Shaw. She was an 83-year-old woman, I think that was her age, who just did not want to have an amputation. And her foot looked like this. That's gangrene, that's yucky. And she said, "I'm not doing it. You cannot cut off my foot, you can't cut off my leg, I'm not going to do it." And so the referring physician decided to send her to Charles' daughter and said, you know, you've been talking about doing this thing. Why don't you try it out? And so he actually, he got the perfect patient. She had a single stenosis here in the distal SFA. He dilated it with these serial dilators, got it open, and she healed her foot naturally and died 3 years later from a totally unrelated cause. So daughter actually, with that, set up sort of the way that we treat patients. He wrote in the chart, and he kind of writes like Ziggy, which cracks me up. So here's, you can see over here, this is the chart, and then this is his typed up report. But look at this, he writes, you know, his observations, and then the bottom, it says, suggest anticoagulant therapy and rerun of oscillometrics, etc., will follow with plasmathography. So he's not only like in the notes saying like what he saw, he's making a recommendation for patient management. This is like huge for a radiologist to be stepping over that line. And so here he's like typing it up, and he puts it even more you know, directly here. So he's basically making a prescription for how we should not only treat patients, but be involved in their care. And so then, you know, he sort of saw the writing on the wall a little bit. He said, you know, if my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, they will become high-priced plumbers facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skills still others can learn. And so again, he's telling us, you know, we have to be involved. We have to be clinicians, because these tricks that we know, they can be adapted or learned by anybody. So this picture, I love this picture. This picture is Laura Shaw walking towards an open door. And for me, this is symbolic of the open doors that were thrust open by this bold move of daughter to try to open up her distal S, and of her bold move to let him do it, right? And so now we've opened up these doors, and no longer do we have to fillet people to improve their physical situations. We can now do things through a pinhole. So it was actually not something that caught on like wildfire, like you might think. I mean, what could be better? Go through a pinhole, you fix them, they save their leg, you don't have to have amputation. But it turns out that it would be a decade before anybody in the US would really like kind of be nice about this. So daughter ended up getting a request, this visualize but do not try to fix request, which is so famous on this one patient. And it turns out, I think it was for the left side. So daughter saw a stenosis on the right and ended up fixing that, because he's like, well, you didn't specifically talk about the right. That was kind of his attitude about things. So, you know, meanwhile, so I'm telling you that, you know, it was a while before people kind of caught on. You know, Charles' daughter didn't do a whole lot to sort of make it a lot easier for his colleagues. He got this moniker Crazy Charlie because, you know, they took a picture of him, and I'm sorry, you can take a picture of me at any point in a procedure and I never naturally make that face. You know, I just don't. and moreover, that is a baby, you know, like that's just not, this is not a picture that I would ever, like a promotional photo that I'd put together. So, you know, he would do things like this. And when you talk to the people who knew him, they were like, you know, he was a showman, but he just would do these crazy things. And some people would kind of blame the surgeons on calling him Crazy Charlie, but and nobody who actually really knew him called him Charlie. So this was sort of a, you know, a degrading moniker, but a little bit of responsibility in it. And maybe there was some good to that, because he definitely was memorable. So, you know, I told you that in the US they had a hard time kind of catching on to this, but in Europe they didn't. So Zeitler, and you also have here Andreas Grunzig and daughter on the right. These three guys were very important for the early days of angioplasty. And actually Grunzig improved upon it with his balloon. He made a balloon that, so you wouldn't have to stick these coaxial dilators down that daughter had originally invented. But it was thanks to these guys that angioplasty really got off the ground. And so, you know, as a testament to the fact that this was really something, it's turned into a multi-million-dollar, probably more, industry. I mean, this is just from Europe. This is IR and cardiology. Look, I mean, just look at this trend. It's gone way up. So they, you know, Daughter didn't realize that he had found this big gaping hole in the value chain, but he found it and he said, you know what, I can make it better. And make it better he did. And he also, in doing so, opened up the possibility for radiologists to now use the imaging that they saw and to make patients better using imaging guidance, looking inside from the outside instead of having to directly visualize with a big incision. And this is what IR is today. It's this huge field that is so rich and vast. Actually, this is Fred Keller that I told you about before. Excuse me. Up here is Ann Roberts, who I also told you about. And there's just so many different things that are available through this field. So it's kind of like, how is it that it's not the first choice of everyone? How is it that everyone hasn't heard of it? And it's because of this phenomenon that I sort of have conceived of. It's because we're on our own little island. This is what I call interventional radiology island. And it's this wonderful island where we all kind of talk to each other and we interact with each other and we put our heads down and we work really hard and we innovate and we push our field forward. But everybody else is over here, you know? And they don't know that we exist. And maybe there's like some other little islands where, you know, other little pockets of people are doing things, but we're not communicating back and forth. And we're not letting people know what we have to offer. And it's not like we're selling snake venom, you know, we've got this incredible way of doing things that keeps people whole, that allows for, you know, hope where there is none in many cases. We are creative innovators. We find solutions where other people are stymied. I mean, just on my birthday, I turned 40 this year because I've been in school for friggin' ever. And I got called in. I was on call on my birthday, of course. And I got called in the middle of the night. And it was a case of a guy who, quotes, fell from a second-story building. I'm pretty sure there was methamphetamines involved because he landed on his feet. He probably thought he could fly. And he had been in the OR. And they had, like, opened him up, and they were trying to stop the bleeding. And they couldn't stop the bleeding, and so they sewed him up, and they called us, and they said, you know, you've got to come. This is ortho. They're like, you've got to come. You got to stop the bleeding. This guy's he's exsanguinating. And we got in there. It was the median sacral artery, which is an artery I'd never cannulated before. We had to use catheters that we're not used to because Cook has had that massive recall that's affecting us all. But it was something that, you know, we worked around all of the issues, and we were able to get into that artery, embolize it, and save this guy's life. And that is because we have all these fantastic tools. So why are we in the dark? So now we're going to talk about some of the fallacies that people spew when they try to explain what happened. And I'm telling you all this stuff not because I want to be like, you know, Debbie Downer or, you know, for you guys to feel despondent. I want you to understand that there is so much hope and so much possibility in this amazing field that if you do choose to go into it, you're going to A, never be bored. You're going to B, never feel unfulfilled if you're doing it right. And C, there are so many ways that you can push the frontiers forward. You're only limited by your own imagination. So when you hear this BS about, you know, this or that, I'm going to go through the meech, I want you to think about it and think about how we can be different going forward. Okay? All right.
Dr. Newton?
Yeah.
Can I ask you a question?
Absolutely.
Do you think we're in the dark because other specialties don't want to acknowledge how awesome we are, or they just don't know?
I think that that it's mostly they don't know. That I think it's more that we do good work in dark places. We keep our head down. Some people call us like the snipers or the stealth attack. And when you're so, you know, good at coming in and out unperceived, you know, just somebody gets better and they have a tiny little Band-Aid, you know, you have patients who go through IR and don't ever know they were there. I mean, we have data. We did a study of people in the waiting room and patients who were even there for IR procedures and had one before, so they had never heard of IR. And it turns out that a lot of primary care physicians haven't either. I am married to a pediatrician, and he sent out an email, and I can't even believe this. He sent out an email to his entire practice just a couple months ago to announce that our documentary had been released on Amazon. And he said, you know, check out this where my wife is talking about ways of doing surgery with less invasively. And I'm like, it's not surgery. Like, I just was going to say it. And he got so angry because, you know, he felt like he was supporting me. I'm like, yeah, but you're missing the entire point. So people just fundamentally don't understand this. And of course, that's my husband. So I go blah, blah, blah. And he hears like wah, wah, wah. But like, you know, hopefully the other, you know, people that we talk to are listening. And it turns out that maybe they're not. So we've got to be better about promoting what we do. And, you know, I work at the VA. I don't make any more money if I do no, you know, 1 million procedures or 0 procedures. I'm passionate about this and do this, you know, in my free time because I think that it is a public health issue. We have to let the public know what we have. So that is what I think. I think that we are very few of us, you know, relative to other fields, and we're not visible. So the first fallacy is this, that we did not protect our turf. And here's a guy who thinks he knows something about protecting turf. You know, you can build walls around something, but that is a short-sighted type of solution because the wall, you know, walls can be jumped over, they can be circumvented, they can be, you know, somehow a defect in a wall can be created, and that can be in an ideological wall or a physical wall. So that's not the way to protect your ideas. The way to protect your ideas is, there are many different ways. The more kind of traditional ways are like they did originally, publications like Daughter published, and patents. And actually this is a patent from Grunzig on his first balloon. Actually, he published on this first, so this patent was rendered, it was kind of negated by the publication predating the patent. So if you're going to get a patent, understand a little bit about patent law and don't blow it by telling everybody your invention before you get a patent. But this is the way that you start. And publishing, people did. It actually, the number of publications rose quite dramatically over, you know, the 20, 30-year span from the beginning of the first angioplasty. And actually, this picture right here is from, if you've ever been to the Daughter Institute, this is the lab inside the Daughter Institute. It looks like your you know, grandpa's garage, and it's like all these like little instruments that they're making. I mean, I absolutely adore it. Like, you have behind here are just like a wall full of wires, and then they got all these little things. They're tinkering, like somebody made some little man stuff, but this is where all the brilliance happens. I mean, it's like completely unvarnished and amazing. So just so you get a little view inside. So by 1980, there were already 177 articles, 17 of which appeared in a single issue of AJR. So this is, you know, kind of a massive explosion of articles. When you have competitions, you know, so we're talking about turf battles, and so they get the word out and they, you know, kind of put a stake in the ground. But when you have competition, competition isn't a symptom of failure. It's a symptom of maturity. It's a symptom of the fact that you have some idea, or you're onto something that is so amazing that other people want to do it too. It's kind of like when you're a little kid and you're like, why is Cindy copying me all the time? It's because, you know, it's a compliment. Cindy wants to be like you. So it turns out that we landed on something. I'm going to count myself as one of these people, even though I came late, but the early guys landed on something so amazing that everybody else realized it's, you got to take part of it or you're going to perish. So here we have IR, we have interventional cardiology, we have vascular surgery. You can see even just between years 2003 and 2004, you've got the interventional cardiologists are picking up what they're doing. You know, the IRs are going down. You've got more people in vascular surgery doing more things. And so this competition is a natural thing that occurs. So why? Is it a numbers game? Well, here we are, interventional radiology. There aren't that many of us, but look, interventional cardiology isn't that far behind. They're right here. And look, vascular surgery is pretty close. And the reason why I talk about these guys is they're the ones who are also doing minimally invasive image-guided procedures. So if you look at like the number of active physicians, you know, how with the percent that are increasing, IR is one of the places where there's the biggest boom. Interventional cardiology is the only one to outpace it, and it turns out that vascular surgery isn't as popular, but we're growing at a pretty big rate, so it's not really a numbers game. And anyway, you know, if you think about turf, people lament this whole loss of interventional cardiology like it was ours to keep, and it turns out that if you know the history, that's not how it went at all. So here's Grunzig over here. Here's his balloon, and the first coronary angioplasty was actually done between Grunzig, Dr. Meyer, and a doctor whose name I'm forgetting because I don't get to use my notes because we're presenting in this manner. But he was a cardiovascular surgeon who actually had the brilliant idea of saying, look, we're going to do a bypass on this patient anyway. So come and do your angioplasty, and then we're going to bypass them so it's safe. And you're going to do it under general anesthesia. And so actually, Dr. Meyer and Dr. Grunzig went and spoke to the patient and their family ad nauseum and got this like mega consent. They consented. They did this. They did it safely, and it was a collaboration between Grunzig, who was a radiologist. He later on also became a cardiologist. Dr. Myers, who was I believe he was a cardiologist, and then a cardiovascular surgeon. So there you have it. From the very beginning, a collaborative atmosphere, which paved the way for one of the most important procedures that has been developed. So this Charles Daughter, you know, he had a lot of inventions and he saw a lot of things kind of coming. I already quoted him a couple times. And he saw the writing on the wall here too. He said, while it's likely that coronary artery dilatation will fall to the cardiologist, and by that he means fall exclusively to the cardiologists, who through self-referral have taken over coronary arteriography, which by the way used to be done only by radiologists, it will be up to angiographers to further the objectives and accomplishments of transluminal revascularization elsewhere. So he's telling you, hey, you don't own these cardiology patients, the cardiologists do, and they just realized that, you know, this is a really amazing technique. So instead of crying about it, find different places to use this. And he said the same thing for vascular surgeries. And vascular surgeons are understandably still reluctant to accept the catheter as a respectable alternative to the scalpel, but it is now evident that they will have to look at its accomplishments carefully. This is 1980. And guess what? They did. Here is the website for the Society of Vascular Surgery. And they actually have on their website, 8 of their 14 listed treatments are actually endovascular. And they use these, you know, the benefits are things that we say, you know, like minimally invasive, percutaneous, like these are all things that they originally disparaged. So look at this like kind of turn. And it's because they realized that either they had to embrace this or they were going to be, you know, supplanted completely. Excuse me, I'm going to cough a little bit. All right, I'm back. So I think I said earlier that this whole minimally invasive image-guided procedure, which is a term that we have tried to encourage, it's not one that we invented, but minimally invasive image-guided procedure can be shortened to MIIPs, M-I-I-P-S. And why did we have to resort to this kind of obtuse acronym? And it's because while we were trying to figure out what to call this thing that we're doing, the surgeons were like, hey, this minimally invasive thing is a great idea. Patients don't want to be maximally invaded. They would like to be minimally invaded. So why don't we call it minimally invasive surgery? And now you see like these doctors, these surgeons walking around with it embroidered on their freaking coat. And they even have an American Institute of Minimally Invasive Surgery. And what do they say? Small incisions, fewer stitches, faster recovery. And we have the slogan, no surgery, no stitches, no scars. And so they're basically touting the same things. And guess what? This is better. If they can accomplish the same thing, why wouldn't you want shorter hospital stays? Why wouldn't you want less pain and getting back to normal activities sooner? So these ideas are really good. And this is what I mean by saying that when Daughter and Resch and all of the other luminaries sort of started this field, they were not simply starting a field, they were changing the entire face of medicine towards a more minimally invasive approach. So this is, when I say that I don't like this idea of walls, it's because I don't believe in walls. And this is a quote by Stephen Johnson, who is a kind of a philosopher, sort of a pop philosopher, put it like that. He writes, "We are often better served by connecting ideas than we are by protecting them. Environments that build walls around good ideas tend to be less innovative in the long run than more open-ended environments. Good ideas may not want to be free, but they do want to connect, fuse, recombine. They want to reinvent themselves by crossing conceptual borders. They want to complete each other as much as they want to compete." So I put forth to you guys, when you start to feel like you want to build a wall around your idea, find out first if it's patentable and then share it. And this is kind of my idea of with surgeons. Everything cannot be solved with a scalpel, and everything cannot be solved with a catheter. We got to work together. We have to interact and find a way to maximize each other's offerings so that for the good of patients. Is there a question? Nope. Okay. So I told you a little bit about Barry Katzen. Here he is. This is Miami Cardiac and Vascular Institute, which you guys may have heard of. He founded Miami Vascular, I want to say in '87. Again, I don't have my notes in front of me, but he actually had this idea and was practicing this way before founding it. And what it is he based an entire practice on an organ system. So he calls it the pump and the pipes. And he brought together other physicians and IRs to treat patients with conditions affecting the cardiovascular system together. So surgeons, medical doctors, you name radiologists all together. And it's an innovative way to practice. And the way that he's been able to do it is to be basically fair so that everyone has an equal place. And it's thanks to his leadership, really. And here is kind of screenshots from his webpage, not just his webpage. I mean, there are lots of people involved in Miami Vascular, but just so you understand, they're extremely public facing. They have this less invasive, more inventive. I mean, it looks extremely enticing, and they know how to reach out to the public. We at UCSD are doing this too. Ann Roberts actually teams up with some of our OBGYNs to provide fibroid care. And this is what I'm talking about. Like you don't have to fight other fields. You don't have to draw a line and say, you can't cross this. I'm the only one who knows how to do this procedure. I mean, they can learn to do a procedure. There's no magic, If you work together and you do what's best for patients and you advance the field as a whole, a rising tide lifts all boats. So Joseph Resch gave the first Joseph Resch lecture at SIR-RFS. This was in 2003, and he gave the following advice. Number one, we should establish our own specialty. Well, we've done that. Number two, we need to assume clinical responsibilities, and this is what Daughter was saying from the beginning. Number three, we need to change training. So shorter imaging, include surgery, extend interventions, and we have the new IRDR residency. And then number four, form partnerships with clinicians, and that's what I've just been saying to you. So these smart people were smart for a reason. So how, instead of building walls to keep people out, you should be building walls to uplift things. And that's how you create innovation. So the walls include credentials and standards so that you maintain that there are high levels of the way that things are practiced. Patents can protect good ideas. Publications and outcomes research also can put a stake in the ground, but also can promote good ideas. Cooperation across different fields, but also establishing your own independence. And then finally, none of this is anything without public outreach, education, and marketing. Unless you think that these things like marketing is an icky tool or some sort of self-serving device, I'd like you to keep listening on, because it's actually a very powerful way to influence people's behavior for good. So here's another fallacy. If only we weren't called interventional radiology. Who's ever heard that? Does anyone have anything to say? Because I just keep going on and on.
There is a question.
Oh, there is? Because they're not showing up when I have this thing minimized. I can't see. So if there are, just, speak. I don't actually see the question. Oh, how do you sell?
I can read.
Yeah, here it is. How do you sell the diagnostic group on taking less diagnostic? Sorry, I have to expand it. Can you read it to me, because it's not coming up right?
Sure. How do you sell the diagnostic group on taking less diagnostic call to cover IR call? Also, not protecting your turf is a lot harder in a small private practice. 10 years ago, before my time, the diagnostic group, that's all I have.
Okay.
Oh, trained the surgeons on a few cases. And about 5 years later, there was a new contract that cuts out IR from the diagnostic group.
Mm-hmm. So so that kind of push-pull with the diagnostic group is a big issue, and it's across kind of the country. And some people feel like the way to deal with that is to divorce oneself completely from diagnostic diagnostic radiology. Other people have found kind of a happy way to coexist. But from my perspective, the way to convince people, to sell, this is again a marketing question, is you have to communicate value. And so right now, diagnostic radiologists, their value to patients is becoming less and less. They're in a commodities race to the bottom, because they are being forced to do more and more reads and charge less and less, which is just a losing game. And so if they're involved with IRs can be the link to their survival in a practice. And the way that is if they're involved and they have a face-to-face kind of interaction with patients, then they can provide that patient interaction that gives value to the entire practice. Otherwise, things are going to get farmed out, because it's just as easy to read in a vacuum from another country than it is to read in a vacuum from inside of the same hospital. So unless they provide value and interactions with referring physicians, until that time comes, and things are going to have to change in terms of the amount of work that's expected of our diagnostic colleagues, I believe that IRs provide that missing link. Does that answer the question? But it is a struggle, and I think we're misunderstood even by our own diagnostic colleagues, and that's kind of underscores the whole point. Okay, you'll let me know if there are other questions, because they're not actually popping up for me. All right, so is there another one? No, okay. All right, if only we weren't called IR. This is one that I just, what are we to be called? Interventional surgeons? Like, would you like to be associated with this or with that? I hate to be gory. You're probably, I haven't had dinner yet. You guys are probably on the East Coast and have already had dinner. But, there's a place for amputation. And I'm not saying, there's not a value to surgery. There's an enormous value to surgery. But we are not surgeons. And that is precisely the power of what we do. It's that we go through a pinhole and we keep people whole. If you need surgery, fine, you need surgery. But what we're doing is completely different. And to want to be called interventional surgeons is a huge misunderstanding of our value proposition. People have come up with a lot of different terms, you know, minimally invasive specialists or this or that, and that's fine, but it's really, the problem isn't necessarily in the name. What's in a name anyway? A name is a representation for something that means something. So until it means something, it's really useless. Look at Mayo Clinic. So Mayo Clinic, you guys, probably 100% of the people on this call have heard of the Mayo Clinic. You know, do you have any brand confusion with mayonnaise? No, you don't. You hear Mayo Clinic and you think this is a place that is an authority for source of medical information. They're trusted, you know, they're good, right? And how they've done that, they just didn't wake up and become the Mayo Clinic. They have put a lot of effort into it. They have an entire a section devoted to social media, a department. They put a lot of thought into their website, into their social networking. So this is a concerted effort, and you can become the Mayo Clinic, and you can become somebody that means something by reaching out and communicating with the public in that way. And that helps sort of deal with the issue that we have, which is that we are the jack of all trades. You know, what do you call us? You know, for other specialties, they may be defined by either you know, the type of disease like oncologists, or a part of the body like a cardiologist, but we're all over the place, you know. So what do you call yourself? Well, you can get around it by saying, I am the, you know, the blood clot specialist. I'm the vein expert. I work at, you know, the Vascular Institute. I work at the minimally invasive cancer center. You know, you can call yourself whatever you want. It doesn't have to be an interventional radiologist. That's really not even the point. And so if you look at this guy over here, listen to your heart, at risk of pulmonary embolism, see the clot busters. Do you know how long it took me to find out what type of doctor the clot busters are? But if you're a patient, who cares? If you have a clot, you want it busted. That's all you want, you know? So what is it that you do? You need to start talking about it. And when we repeat this over and over, this minimally invasive image-guided procedures, I told you it's awkward, so we shorten it to MIIPs. By the 200th time saying it, you know what, it means something, and that's all it has to be. It's like Nike or anything else that you say a bunch of times and it means something. Excuse me. By the way, Nike didn't just become Nike, you know, like there's a whole lot of marketing that went behind that swoosh sign, and now you don't even have to write the word Nike. You just show the swoosh and it means something. So that's the power of marketing. So the next fallacy, which is just really sad and naive, and I think you know, rooted in goodness, is that we just need to be the best. And what the hell do you think we've been doing all this time? Like, we've been doing really good work, like I said, in dark places, and doing good work without anybody seeing is not enough. Excellence does not equal recognition, okay? Excellence plus visibility, now that equals recognition. And why do you care? I mean, if it were just us being excellent and doing good work, you know, for a few patients, then that's fine. We help one patient at a time. But what we lose out on is the opportunity to do good for every patient who could potentially benefit, and to give patients the power to make the choice for what's best for them. So how do we do that? So that, you know, having excellent skills is important. Multidisciplinary conferences is important. So are publications. Original research are definitely an important component. Complete patient care, where we have this longitudinal model, very important as well. And all that's going to lead to more referrals. So you'll have a good reputation among your colleagues at your hospital. And if that's all you think of, then okay, that's fine. You know, in your little province, you'll be king. But if you add something else, public outreach, that raises opportunities, not just for you, not just for your patients, but for any person out there who has the potential to benefit from these amazing, life-saving, life-changing procedures that we offer. So that takes us to our next fallacy. Marketing to the public is a waste of time. Well, Donner didn't think that. He actually was a great artist. He drew this. This is the sort of logo for IR. He called himself a plumber, right? Some people really hate that. He has this like t-shirt, "Get it dilated with a daughter angioplasty balloon by Cook." I mean, come on. Like Sunshine Act in California would be like, whoa. But you know, they use this sign here, artery cleaners. They made a movie. So like the fact that, you know, Susan and I are making movies now, this is nothing new. There's nothing new under the sun. This was done by Daughter and Resch, you know, back in the 60s. So all this stuff is, he recognized the need to reach out to the public. And in fact, this is a Life magazine article where they first described the angioplasty, and he got himself like placed there. I mean, so we started pretty strong. Like, where did we go wrong? This is actually a quote from John Abley from an article that he wrote. And he said, you know, please devote more effort to promoting the value of interventional radiology to the public, to the government, to the primary care physicians, to insurance companies, hospital administrators, and all of those people who may influence the acceptance of this specialty. Consensus statements, patient education brochures, and speakers bureaus can all contribute towards this objective. Some activities are taking place, more are needed, and more people need to be involved. And then he says, as a friend but an outsider, I am sensitive to offering gratuitous criticism and suggestions, but so many good things are happening technically and medically that to see less than the full promise of interventional radiology achieved is frustrating and disappointing. We owe it to Charles' daughter and the other pioneers, as well as to prospective patients, to help their dreams come true. I mean, to me, you can't say it better than this. You know, I love this guy. Like, this is exactly how I feel. I feel this passion to spread the word and to be all we can be. So IR offers solutions. So what's the role of marketing? Well, in marketing, marketing is to understand the problem. So who are these people that may need MIIPs? What matters to them? You know, is it to get home to be with their family? Is it to get back to work early? What alternatives are available to them? And then recognize the value of the solution. What needs, advantages, and limitations of our alternatives. So if you're going out there being like, oh, I can solve everything with a catheter, you're misrepresenting and you're doing it a great disservice. The cost and the cost savings, and not just of the procedure in a moment, but over the entire span of a patient's illness. And then you need to communicate that value to the patient and to the provider and create an experience that delivers that value to the patient. And then feedback, do a loop, that go back to IRs and say, hey, this is what we've learned to enhance that value and inspire new solutions. So that's the role of marketing. So marketing for IR Island is the link between the mainland and this place that we've been, that was erected, you know, back in the 60s by the genius of the luminaries. Now it's, you know, easier than ever. We've got all these ways of reaching out. You've got the power of social media, many ways to interact, not simply with swaths of people, but individually, one-on-one, in a meaningful way that allows people to interact and engage, not simply be told to, but that they can talk back. So here's the Mayo Clinic. I mean, I told you they worked really hard. At the time that I updated this, they had greater than 887,000 likes on Facebook. They are, you know, they had over 1.27 million followers. You know, this is a big deal. You know, and they were named by the Harris Poll Equitrend survey as the top health information website over WebMD. And look, I point out Miami Vascular. They've got these very patient-oriented images and things that they put on their website. Here's another one. So Daughter said catheters should replace scalpels, or you know, there would be a way that we could replace scalpels with catheters. And so we created this documentary, Without a Scalpel, which is now available on demand on Amazon and Vimeo and a host of other platforms. And you can go see it. It's 43 minutes, or you can watch the trailers. We have various trailers or teasers at theii.org. And the point of this is to communicate to the public the value of MIIPs. And we do it by telling stories, because now, you know, people learn in that way. And you wouldn't believe how people have come to us and said, wow, I had no idea this existed and I want to learn more. And so it's not a one-off. We started a nonprofit called the Interventional Initiative, and it provides information to the public at the recommended 6th grade health literacy level so that people can understand what options are available to them. And we have the phrase that we coined, there's a MIIP for that, so they understand what there is a MIIP for and what there isn't. So the fallacy that's kind of disturbing is that we need to control the patients. If only we controlled the patients like the cardiologist did, then all of our problems would be gone. Well, complete patient care does not equal patient control. You know, Murphy and Soares wrote this paper in 2005, and they said, vascular surgeons and cardiologists often claim that they, quote, control the patient. This is also erroneous because no one controls patients. According to the AMA Code of Ethics, patient autonomy needs to be respected. Patients can make their own decisions. Well, it's even more than that. It's actually been shown in research that if you empower patients with the information to make informed healthcare decisions, their outcomes are better. So that's why PCORI, Patient-Centered Outcomes Research Institute, was started. This is independent but heavily subsidized by the government to find patient-centered solutions. And so we believe that knowledge is power, and for that reason we started the Interventional Initiative, and I encourage anybody who's interested to check us out. And if you want to become involved, we'd love to have you. We want passionate, engaged people who want to make a difference to come join our ranks. And we've got really great people in the II. So here's a fallacy. We can find the answers by talking amongst ourselves. And this is not a fallacy that anybody would ever utter, but they just do it. We do this all the time. We think that we're saying these great statements and we're just talking to ourselves all day long. And here is Interventional Radiology Island, and we're on there, and we're, you know, what we need to do is this, and we're just so great, and we offer minimally invasive, and right now we're actually doing this very thing that I'm talking about. I'm talking to a bunch of other people who already know about IR, about the value of IR, so preaching to the choir. So John Kaufman, who was one of the people that I mentioned, he wrote this article, which I just, and I pulled this quote because I just think it's so brilliant, and I'm going to read it to you. So it's basically about how we innovate in this day and age must change dramatically from how we innovated in the past. So he said, Charles Daughter created many of his prototype devices by himself. This will not work today. In order to fully capitalize on the potential of advances in materials, drugs, biologics, sensing, informatics, guidance, manufacturing processes, and marketing, an organized collaborative approach to innovation is required. This means collaboration across specialties and across professions, between institutions, with patients, with industry, and with government. The more that we can make collaboration an integral part of the culture of image-guided intervention, the more we will be able to achieve. And that's profound. You know, we're going to have to look outside ourselves. It's not simply incremental changes on these things that we've already invented. We've got to think about the things that nobody's thought about. We have to imagine things that are simply, you know, beyond imagination. And how we're going to do that is you guys, everybody on this call, you have the power to make these kinds of innovative changes and to think about things, to be looking at something and go, hey, that could work inside a vessel, or what if I adapted that for this? That is the beauty and the passion and the intoxicating allure of IR, and that's why you should all become IRs. So, in conclusion, turf defense is ultimately futile and counterproductive. And so what do? You don't just pee around the perimeter and expect people to stay out. You create new and more fertile turf through innovation, through research, through ingenuity, and collaboration. You know, my daughter my daughter thinks that the presidential candidate is Donald Trumpet, and she's like, "Don't be like Donald Trumpet." So take that and think about it. We need to recognize and capitalize on our value. So we do it minimally invasively. We are not surgery. You know, if you want to be respected, and you think that to be respected you need to be called a surgeon, then you need to redefine what it is to be respected, not change the name. I mean, that's just ridiculous. We have value in our technical skill. I mean, it's been honed through years of doing the hardest cases and the riskiest patients. We are imagers. I mean, we're like the complete package. We can understand the imaging findings. We can manipulate them. And we're creative and we're versatile. We find solutions where there are none. And then finally, it's not enough just to do that quietly. We've got to communicate this value. We got to do that through publications, through public education and engagements, and let patients decide, and through marketing. We have to unify our message and repeat it ad nauseum until people know what MIIPs are, until people know their options, and they can choose from them in an informed way. We have to empower the public. So those are my references, and I am happy to take any questions.
That was great. Thank you.
Thank you. Am I talking to anybody besides just you, Natasha?
No, there's 30 people still on.
Oh, okay.
Yeah. Does anybody have any questions? If you do, you can type them. You can just start talking.
So I actually have a question, Dr. Newton.
Okay.
In talking about being a clinical specialist, if I'm an early trainee and I want to do my part in terms of enhancing my skills along the way and becoming more clinically capable as a physician, how do I do that if, say, I'm not at a program that is clinically oriented, say, doesn't do patient rounds, doesn't have a follow-up clinic, these types of things? How can I maintain my clinical skills along the way?
First of all, I just love that you asked that question because it shows that you value that aspect. So you're saying that in your residency program, perhaps, or if somebody's at a residency program where this, you basically are practicing in the way that IR has been practiced forever, and there isn't a movement towards more clinical a type approach. How do you keep up your skills? In my mind, the way that you do that is you communicate liberally and often with other specialties, and you do that by rounding on patients when you can. Like, let's say maybe your attending doesn't, or maybe it's not the culture, but there's nothing stopping you from going up to the floor and visiting the patients, and asking the other teams, like, okay, explain to me why you are doing, or what the plan is, and getting the perspective from their point of view. That is a very important way to understand and to be completely open. You can also do that for pathology. Like, if you take a biopsy, go over to pathology, have them explain to you how they come up with the diagnosis. Find out, when it's non-diagnostic, why, and what you can do better. You can also there are opportunities to improve your skills through courses and things like that, but I think it's more of a hands-on type of thing that you've got to do. If you do any away rotations, try to do them in places that have these types of opportunities, so you can see how IR can be practiced in more of a holistic way. But in reality, what we're saying as being so, I don't know, IR revolutionary is very normal to most other fields. If you think about it, they go see patients, they lay hands on patients, they increasingly just order CT scans, but a long time ago maybe they laid hands on patients, but there's no reason why you can't. So let's say you read a CT scan of someone and you're trying to figure out, well, I'm giving this very long differential, and what does it mean? What's going to stop you from running over to the ER and just doing a physical exam and doing just kind of putting all the pieces together? You may be the only one who thinks that way. You're seeing the pictures, you're seeing the patient, and it all comes together. And I can tell you that since becoming an IR, and because we do that, because we have to, it's part of what we do, I've become a much better diagnostic radiologist because I understand which findings mean something and which ones you can do something about.
Do you recommend that? So I know some residents can moonlight, and it's all dependent on the program and stuff like that. How do you feel about us moonlighting in, like I work in a free clinic, and I also work at a long-term care facility where I act as a hospitalist on the weekend. So that's kind of how I get my patient interaction and to keep up my medicine skills. Sometimes it's brutal, sometimes it's, great experience, and it's all part of learning and working and continuing to grow. But is this something you recommend, or is it better off,
I love that. No, if I found out, so I'm one of the program directors for our T32 funded research residency, and I'm the associate program director for our IR fellowship, and so I read a lot of applications. And if I saw that on an application, I would be like, I want this person, because to me, I don't want, 400 carbon copies of the same path. That's not where our innovations are going to come from. I want people who've had diverse experiences, and the fact that you're going out and getting these experiences moonlighting. So, here in San Diego at UCSD, the moonlighting experiences are simply to babysit a scanner, for contrast reactions. So we don't even have those available to our residents. But the fact that you do and that you're taking advantage of them, that's huge. That means that, like, when somebody orders something and you don't understand, or somebody else might not understand it, you can say, well, the rationale is this, because yeah, I still do have this clinical experience. So that's a great point. I love that. I love anybody who's had a different type of background. Like, if let's say you came from a film background, or let's say you you did history or whatever. To me, like, having had diverse experiences only enhance your ability to come to the table with a different skill set and different ideas. So that should be celebrated and not suppressed. You shouldn't all try to be the same, prototype of the perfect IR applicant.
There is a couple questions. Two of them kind of go hand in hand, so I'll read them to you at the same time.
Sure.
The first one is, for those of us hoping to get involved with the II, are there opportunities to contribute regardless of level of training, med student, resident, or fellow? And in conjunction with that, it says many of the medical students don't know about IR. What is our plan to market medical students?
Okay, those are perfect. So for the first question, absolutely, you can get involved, and you can email me at isabel@theii.org, ISABEL @theii.org, or at my UCSD email, which I don't know I think it's available with this thing. It's inewton@ucsd.edu. And let me know that you're interested, and I'll send you an invitation to become a member, and you can learn more about it. And we have a lot of members. Actually, we have a medical student, Ken Nakanote, who is now contributing author to Huffington Post, and published a Huffington Post article about TACE, and a patient who had TACE. So we have people who are contributing in lots of different ways, and we'd love to have you if you're interested. If you want to market to medical students, you're welcome to use our teasers, or even just show the documentary. People are doing that across the country. I know that at Yale, all of the medical students are shown this in one of their courses, or at least that's what I'm told by Claire. And this is in more than one place. And so I showed it to a bunch of med students and also pre-med students, because we have to start appealing even earlier on the campus here, and they got very excited. So it's a way to sort of communicate in a very succinct fashion what IR is about. And so if you'd like to show those, you're absolutely welcome to, and you can contact us about more information.
Awesome. Does anybody have any other questions? These are just the ones that are
it's
listed.
Funny because they don't come up completely. Let's see. Anything else?
Okay. Well, if you guys don't have any other questions, or if you think of something after the fact, my contact information is on the RFS website, and you can either contact me and I will get you in touch with Dr. Newton, or if you remembered and wrote her email down, you have it. Just let me know.
Sorry, would you like to ask one question?
Sure.
Yeah, absolutely.
Sorry, I was following up on a patient from a week ago. I had been off, and I looked back in the chart. I'll give you the short story. Older patient, diagnostic dilemma. Apparently they had been to another tertiary care center. Everybody's chasing the diagnosis of, think this is pancreatic metastatic disease somewhere. The surgeon calls me because her chole tube had either come out or been pulled out. She ends up with, cholecystitis again, and also has bone mets or has bone lesions now. And he calls me and says, hey, can you biopsy this bone lesion and put in a chole tube? Of course I can. I'll take care of that. So I follow up a week later, and I'm just kind of finding out, okay, we got the diagnosis. Apparently everybody else, all their endovascular ultrasound, everything else failed. I biopsy the bone, we got a diagnosis, and I look in the discharge summary, and I'm sorry, maybe I'm being a little bit snide, but of course it says consults during hospitalization, and IR is not in there anywhere. They consulted surgery, they consulted GI, they consulted, neurology, everybody else, but IR is just like an enigma. And I guess this all goes back to your point from the very beginning. Like, I feel like I really helped that patient, but it's like we were so good and so quick and got it done. Two great things to help this patient get better and get out of the ICU and go home probably. And now that, of course, they've got a bad diagnosis, but you got them the answer. But it's almost like, well, that's why nobody knows who we are, because
that happens all the time. You know what I do? Every time I interact with patients or their families, I take a moment to explain to them. I'm like, I tell them my name and I say, I'm an interventional radiologist. Let me tell you what that is. And I just take a moment, and it's to educate, but also to make them have a sense of context, because otherwise we're just these weird thing that they never heard of coming in, on the scene, and they're like, I just see all these doctors, I have no idea what this is. And it turns out that I've had patients tell me, you know what, I remember that interaction with you more than all these other people who come and go, because you took the time to tell me about what it is that you're doing and put it in a context. So that's a way to sort of deal with it. I don't personally gain from their knowing or not knowing, but I think that we need to start as a group spreading the word in this way, educating people one person at a time, and then also in this larger way. So
I agree, and I actually try really hard. I've gotten a couple little, silly patient comments, and I'll get administrators will bring me, candy or something, something silly, like you're getting a lot of comments from patients. But my comment was about the hospitalists, who are supposedly the quarterbacks of the future healthcare, where they're going to be the ones who are quote unquote directing healthcare, which I'm not going to go into that whole spiel.
Yeah.
But it was just funny, and again, I understand it's a process. And like you said, I think the comment is it's an everyday mentality. You just have to be able to go to work every day and be thankful for what you get to do, explain it, and move forward. And eventually, just like one domino causes many to fall, you just got to keep knocking down one domino a day.
Right. I agree. That's wonderful. What was your name?
Patrick Robbins.
Patrick, thank you so much for your comments. I wanted to also, there was a question here. It says, is the answer to do formal consults as other services, surgery, do before procedures? I think we have to behave like a real, service. And there's probably going to, now we're modeling ourselves after other services, and there's probably going to be, an evolution towards something that works well for being able to do a lot of procedures. Because if you look at surgery, they don't operate every single day. No surgeon operates every single day. They have a way of doing it. But we do have to treat every patient as important and think through every single thing that we do and interact and talk to them, talk to their families. And that does take time. And there are ways to kind of balance the workload. Some people have ancillary providers that help, but I do think that that's an important
Can I make one comment to that?
Absolutely.
Real quick? Just because I work in a group of 10 radiologists, so it's not a very big group. We work for 2 hospitals. Mm-hmm. And in one hospital, we have a EHR, and I actually went to the EHR, and I'm just making this comment for those to file it away or whatever EHR they work on, but I actually got them to make a note that's titled IR consult. So that way, in the patient's chart, it's very obvious who that IR consulted this patient. Yeah. And I don't know, maybe everybody does that, but I just, again, little things, trying to make little touches, I guess, anywhere that people can see, like, hey, I've been here and I'm following this patient, whatever it is. So that's just a comment.
I love it. That's great. That's a great way. I also want to apologize for my comments about Trump, if anybody was offended. It seems that I might have offended one person. I live in California land, where it seems like everybody thinks like I do, but if you are a Trump supporter, I do apologize for depicting him in less than a glorious light. So.
Does anybody else have any questions, thoughts, concerns? Okay, well, if we don't have anything else, you can see in the question section, I posted Dr. Newton's email address. And everybody, thank you so much for showing up and listening and participating. This was wonderful. Thank you, Dr. Newton, for doing this and for taking time out of your busy schedule. This was super informative and really awesome. And I think there's multiple comments that say thank you. So
yeah, thank you guys. I appreciate it. Thanks for your time.
All right, you guys have a great night.
You too.